So hello, everyone. My name is Nick Richmond. I'm one of the directors of Tricordant, and I lead the organization design and strategic workforce planning practices. And I'd like to welcome all of you to the Accelerating System Productivity and Efficiency through Strategic Workforce Planning webinar. I'm joined by members of the Tricordant team and our collaborators that make up the strategic workforce planning practice. And I'll introduce some of them in a moment. There's going to be Rob Smith, Jax Melander, and Patrick Mitchell. And now Jax Melander is an international health and public policy economist with over 40 years of experience, and she runs a boutique consultancy. Until recently, Rob was the Director of Workforce Planning for NHS England, and now an independent consultant, and Patrick Mitchell was until recently Director of Innovation and Transformation at Health Education England. So Patrick will host the plenary with Rob, while Jax and Rob will be our provocateurs today. And all three are part of Tricordant's strategic workforce planning practice team. And we have a number of other team members, but you can connect with them maybe during the breakouts. So our aim today is really to share some good practice, provoke discussion about creating and delivering a business-driven integrated plan rooted in economic analysis. And we have an agenda there, as you can see. We're already into the welcome. Jax is going to be talking about how to prioritize through economic value and where to start, and then Rob about what and why of integrated workforce planning. That's going to be followed by some small group discussions and then the plenary. And we do encourage you to stay on for these small group discussions and plenaries, because that's often where you get some real insights from peers, from colleagues, and from the Tricordant team. The plenary will certainly be exploring what can you do next? What should you do next? So these insights we find really useful and of high value. There's a couple of highlights I just want to bring to your attention. Before we sent out an email saying we'd love to understand what parts of the webinar made you think and why, and would like to hear about the specific challenges your organization is dealing with. And the offer is that for the first 10 people who book, we'll share a thought piece that captures our thinking and ideas to develop an integrated strategic workforce plan. We already have a number of people signed up, so by all means, please contact me and we'll arrange the call. The second is our next webinar, which is coming up in March, on the 26th of March, between 3 and 5 p.m. It's titled Strategic Thinking and Delivery in Complex Systems. And we're communicating about that on LinkedIn and in our 1-minute read. So if you're already receiving those, then you'll know a bit about it. Otherwise, do connect with our Tricordant LinkedIn page, and you'll see a bit more about that there. And we'll share about this in a follow-up email to this webinar. But before we get into this, I'd like to do a bit of a Zoom poll to just get an understanding about what you're expecting to find out about or experience from today's session. If I launch that, you should have an option to answer one of those questions. And if you're going to answer the other, I'd love you to type your response into chat about that. So as you can see there, 40% are really here to learn about new tools and methodologies. And then there's about an even split or thereabouts between being inspired to try something out, or some digestible insights. And that's a fair reflection. I think when we have these conversations and these webinars, there's a similar pattern with others, that people are really trying to understand how to do this and to learning about new tools and methods. And hopefully we'll share a little bit of that, and you'll get some of that in the small group conversations as we head into those. That's probably enough from me, and I'm going to hand over to my colleague Jax, who's going to take us into the first provocation about how to prioritize through economic value and where to start.
Thank you for that introduction. Very nice to see a few familiar faces on this call as well. So yeah, really good to see you. So I'm going to kick off this afternoon's webinar with a little bit of a back to basics, I guess, in terms of the economics of the workforce. That was the brief that Nick gave me, and I guess it's the kind of framework within which Rob is then going to present the meat and potatoes. So I'm kind of the plate, I think. So what I'm going to talk about a little bit is the value of the workforce, what drives workforce value, what perspectives we might want to think about when we're thinking about workforce value, and then really importantly, when we're thinking about strategic workforce planning, what's the relationship between what we're planning to do for the workforce and what we need to do for the wider health and care system. And I'm going to be talking, I know there are some people on this call who are not in the health sector. My presentation is very much focused on health, but you'll see some parallels, I'm sure, in other markets. So let me just kick off. First thing I wanted to say is health workforce has a real contribution to make to the economy. It is not just a cost to the system. It's not just something that we spend money on in order to deliver services and therefore something that somehow we've got to squeeze in terms of cost. It is also something that contributes to economic value. It's taken quite a long time for this to be very well articulated, but I think once the WHO undertook its high-level commission on health, employment and economic growth globally and looked at all the evidence and produced this sort of enormous pack of resources and report investing in the health workforce, it really brought it home just how important this is as a contributor to economic value. So investing in health systems and investing in the health workforce promotes economic growth in a number of ways. It stimulates economic output because employees go out and buy things and spend money, don't they? It stimulates social protection and cohesion. So people who are living in a health secure environment, more likely to be able to go to work and contribute to economic stability and economic growth. Huge contributor to innovation, and a huge amount of innovation comes from the health workforce, and that stimulates science and innovation right across the economy. And then, as we have it recently experienced with COVID-19, it contributes through providing health security. So if your population is health secure, it functions as part of the economy. If your population is not health secure, then we get things like lockdowns and people not able to participate in day-to-day living. So really, really important to think about that value. In terms of the health workforce as well, it tends to not go up and down in terms of economic booms and busts. So you don't end up having that sort of big wave of economic downturns and upturns. It tends to smooth that. It doesn't. The evidence suggests it doesn't contribute to wage inflation particularly. People become health professionals for a number of different reasons, so it doesn't necessarily stimulate everybody wanting higher salaries. And it really does help those other sectors to be more productive. So lots of really good reasons for investing in the health workforce and thinking of it as an asset, as a good, as something that we should be nurturing. Just thinking about the health system itself, a lot of you on the call are from the NHS in England, and as you know, we are adopting along this guidance from the World Health Organization. As most countries are looking at adopting integrated care, the NHS in England is out front with the development of integrated care systems, and workforce has a huge role to play in making that work. And these two curves on this chart is designed to sort of illustrate what the value of an integrated care system might be in relation to what we call the quadruple aim. So, you know, in terms of improvements in health outcomes, improvements in the experience of receiving care, the health system efficiency, now with ICS goals being to contribute to the wider economy. So that value curve without the workforce investment is the expectation is that over time, these integrated care systems will really start to make a difference. Well, if you accompany that with workforce investment, you're you're going to be pushing that curve up. You're going to be pushing it up because you're going to be getting there faster. That's the acceleration value. And you're going to be pushing it up because you're going to be getting better value from a huge part of the resource that's going into delivering integrated care. So the idea is that if we really get this workforce investment right, we can really generate much more value from the integrated care systems than otherwise would be the case. So let's just go back to basics a little bit. I want you to start thinking about the workforce, if you like, as a good, as something that you buy as a biscuit. There you go, and I'd get the biscuits in. So generally speaking, from an economics perspective, for any given, role or level of quality, let's say, or any given biscuit, a ginger nut, for example, my favorite, the supply of that good tends to increase as the price increases. So people, if the price of ginger nuts go up, lots more people will come in and start to supply them because they think, oh, that's pretty profitable. And this curve on this chart here shows that. So as the quantities, you move to the right-hand side, when the quantity goes up, you're also moving upwards in the chart as the price goes up. So that's a very basic supply curve. Let's think about demand. So the demand for those ginger nuts. And it is true to say that for any given role or level of quality, and of course all other things being equal, the demand for that economic good falls as price increases, right? So I know that if if the price goes down for the ginger nuts, I'm going to want to buy more. If the price goes up, I'm going to want to buy less. Now, the sweet spot from a market perspective, from an economics perspective, is that in a well-performing market, the price, where that intersects between demand and supply, is the economic value. So it's the price that the market, if you like, is prepared to pay for that good, for the value that the good brings to those who want to use it, and the value that that generates for those who are prepared to supply it. So here we have the market price being P1, and it delivers a certain level of quantity of supply, Q1. Now, what happens when you set that price lower than the market price is that you get a gap. And you get a gap between the amount that's supplied and the amount that's in demand. And in the NHS, that's quite a big issue because we set our pay bands nationally. And there's lots and lots of evidence from the market, never mind from what people are saying, that there is a gap between supply and demand for staff. And that gap is kind of plugged by agency staff. Lots of NHS organisations have to go out and hire in contractors or locums, as we call them. It's also showing through in staff workforce well-being. If you look at the staff surveys in the NHS, you can see a lot of burnout, a lot of people who are very feeling that they're sort of being made to work beyond their scope of practice or beyond their normal hours. And the worst case, you get service shortfalls. So this in health speak, what this tends to materialize as is things like admission thresholds going up, service thresholds going up, so people's entitlement to services going up because there just aren't enough staff to deliver. We can see it really loud and clear with the waiting lists and the waiting times at the moment for planned surgery and planned care. And all of that sort of pushes into cost pressures. So what can we do about it? So if we look at this from a labour market perspective, one of the things that we can try and do is push that supply up, and we can push it up for any given level of wage or any given price by taking various actions. And I'm sure Patrick will recall from his time at Health Education England, this is a lot of the things that Health and Education England were doing. Trying to promote entry into the labour market through providing career opportunities, improving working conditions, lowering the cost of training. This is a big issue, is trying to put subsidies in to help people train, increase retention of trainees, making the life of trainees a little smoother and a little better, increasing training productivity, so you don't necessarily have to take so long to get to where you need to get. Increasing career life, encouraging people to return to practice, to come back into the workforce. We saw a lot of that in COVID. And then increasing career path flexibility, so people can actually move around a bit more, so it's a bit more of a choice. So that will all do things, that will push this supply curve to the right and increase the quantity supplied. But it's not the only thing that you have to do. So the other thing is to actually try and reduce demand. And this doesn't necessarily mean that you're saying that you want less workforce as such. It may be that we're talking here about improving things like productivity. So for any given price, we want to see if we can get more value. Now that might come not by making people work harder, because that's all that's going to do is deliver more stress, but things like digital enablement, things like using digital tools to really encourage and complement and make it easier for people to do their jobs. Changing the skill mix, that's another way of changing the demand for staff. So the use of advanced practice, for example, reduces necessarily the demand for potentially for some types of medical staff, because a lot of advanced practitioners take on some of those roles. So the other big thing that you can do is redesign care pathways so that they are more efficient and so that there's less duplication and less waste across the system. So that gives you a little bit of a perspective of the kind of actions that you can take in terms of demand and supply to really try and get to grips with this disconnect between the national pay bands and the current state of the market. It's not just about price. Really, really important is the opportunity for increasing value by improving workforce well-being. Lots of evidence now that shows that if you actually invest in people, then their willingness to work for a particular rate of pay and in particular for a particular number of hours is really much more influenced by how they feel at work, whether they feel valued, whether they feel engaged. And so improving workforce well-being can really help the individual in terms of getting longer working life and return on their own investment, on their education and training, can see their career progression move through some of those glass ceilings. And then for the health and care system, this reduces the costs too, because it reduces the amount of time that people are at work but not really working, and we call that in economics presenteeism. It can also reduce absenteeism, so sickness rates come down, and it also reduces the speed at which people move jobs. And all of those things cost the health and care system, and hence the taxpayer, a significant resource. So just to summarize, if you want to think about some of these things in terms of the workforce plan, is thinking about how can we do things like accelerate time to train? How can we do things like extend NHS careers, longer working lives, those kinds of things? All of these are sort of workforce transformation issues. And then also, how can we improve the NHS productivity and better match the supply and demand for NHS workforce to really shift that integrated care system curve, so we're accelerating and improving value from investing in integrated care. That all sounds great, doesn't it? But we all know that health system is funded in this country from taxpayers' funds, and integrated care boards get spending budgets, and that's they have to get best value out of those spending budgets. So we know that health system funding pressures are likely to increase over time. And if you look at this slide, we're looking at an upward curve, which I've called business as usual, which is, you know, if nothing else happened, the pressure on those funds would go up and up over time. And the key kind of drivers for that are things like the fact that the population is growing, the fact that it is slightly older population, and when we get older, we tend to disproportionately use more services. The incidence and prevalence of diseases drives growth, and the availability of new diagnostics and treatments and innovative drugs all are a good thing, but they also drive growth in sort of funding for health spending. And integrated care systems around the country at the moment are calculating what they think that business as usual curve looks like, and then they're comparing it with what they think they're actually going to get. So the blue curve here is the sort of likely available funding. As you can see, I've deliberately drawn it as not increasing at quite the same rate as the pressures are increasing. There's plenty of evidence of that. But that gives you a funding gap. And, ICBs that I've been working with are all facing, 5-10 year funding gaps that are quite substantial. So left unchecked, this is going to become a really serious problem. So a lot of the ICBs around the country are trying to close that gap by developing these strategic plans to achieve affordability. And they're looking at strategic initiatives such as improving prevention, proactive care, lots going on in proactive care, care coordination, and those sorts of things to try and help target on those most in need to control demand for the health services, and all other things being equal, take some of that demand pressure off. There's also a lot of service redesign going on to improve the way that the system delivers, get better outcomes for the same money, or even reducing waste and duplication. And then there's also strategic initiatives to improve specifically workforce value. And that's about system level initiatives to improve the balance of demand and supply, and system initiatives to improve workforce well-being. And I keep mentioning reduction of duplication and waste. This is always and everywhere a really big issue. So if we're trying to put strategic workforce planning and economics together, where do we start? So first of all, I think there is a really important set of work that needs to be done to reduce that workforce gap that I talked about, is bringing those demand and supply curves together in the way I described. So it's thinking about assessing the workforce implications of business as usual and the key challenges and opportunities that that gives rise to in the short and the medium and the long term. And then in terms of economic priorities, really prioritizing early action on system-wide workforce initiatives for addressing the things that the employers within the system are facing around recruitment, retention, well-being, and particularly in the areas facing the greatest challenge and where system responses are really needed. So, this is about, yes, all responsibility for employment sits with local NHS trusts and primary care and community trusts and so forth. But as a system, what can you do to really address some of those issues? And then develop and implement strategies for system-wide workforce initiatives that will be needed going forward. And I've seen some really good examples of ICBs setting up academies, faculties, to try and really look at all the opportunities that are out there now with things like apprenticeships and I mentioned advanced practice earlier on, extended roles for things like pharmacy. So this is what that column is all about, reducing that workforce gap. But then there's another piece to do, which is about reducing the funding gap, again, while protecting or improving, if God willing, quality and outcomes. Let's look at the workforce implications of the strategic initiatives that are designed to reduce the funding gap. And I don't see that happening very much. I don't see that connection being made. And this is all about thinking about what can we do at a system level in terms of investing in actions to support reducing that funding gap, which then have a workforce implication, and prioritize those system level actions to support workforce enablement for those initiatives that have the largest impact. So for example, if you're looking at, I'm going to use a phrase I loathe, but if you're looking at initiatives which are about the shift to the left, which is about developing services outside hospital, make sure that that links through then to your plans for things like advanced practices, the R's roles, all of those kinds of new ways, workforce transformation priorities that would help those strategic initiatives that reduce the funding gap really take off. So that was my starting provocation, and very happy to pass back to Nick, and thank you very much for listening. Looking forward to hearing thoughts and feedback later.
I'm going to hand over to Rob, who's going to take us into a structured approach to service, financial, and workforce planning. So, Rob, over to you.
Thanks, Nick, and thanks, Jack. Good afternoon, everybody. I'm Rob Smith. Spent 36 years in the NHS, initially in finance and service commissioning, but for the last 20 years of my career in the workforce system, both as an education commissioner and importantly as a strategic workforce planner. As Nick said earlier, I was director of workforce planning and intelligence initially for HEE and then NHSE from 2015 through to last year, when I bowed out following the publication of the NHS long-term workforce plan. And it's in that role that I've been pressing for about 7 years for a really deliberate attempt to integrate service, financial and workforce planning. Integration is a tricky word because we also mean health and social care. So in this context, we're talking about the importance of aligning workforce with service and financial planning, as well as doing it for integrated care. And I think what I wanted to share with you today is that I've been privileged to think about why it is that we appear to have these failures in workforce planning. Long-standing challenges in getting the workforce to match the demand required and create all of the right actions that go with that. So I wanted to share that with you, and why that's become more timely is through two things. The sponsorship from service and financial leaders has never been greater. And those two things were initially a lot of lobbying, initially by Jeremy Hunt as chair of the Health and Select Committee for a workforce plan, with lots of support from the Anita Charlesworth of the world and others. And then people's experience of COVID, where the fact that workforce shortage might be the absolute constraint to service delivery, and ultimately one of the key issues associated with lockdown, kind of told people that they probably hadn't been thinking about this enough. And that generated a lot of sponsorship from people like Amanda Pritchard and Julian Kelly, which kind of created an environment in which this discussion might find some traction. And we'll come on to that in a minute. So I'd like to share those insights and experience with you. And critically, we're going to give you some practical structures to use too. For colleagues who aren't from the NHS, my experience is NHS based, but I think these are generic concepts and variables that should resonate with you, although slightly differently in your industries too. So what I've kind of observed over that 20 years of workforce planning is that it's not that workforce planning efforts are flawed because of the capacity or capability of the people doing that planning, but rather there are some more fundamental barriers to making it work. And for me, the key one of that has been that effort has been fragmented and misaligned. We haven't been able to pull disparate effort together in a coherent way. And the first element of that fragmentation has been this separation between service and financial planning and workforce planning. It's really profound. It's almost behavioral and cultural. And it's a huge challenge. We'll come on to why in a minute. And if that wasn't bad enough, we then live in this world where there's a really complex landscape. Lots of different plans that need to be coherent with each other. The nature of the NHS as a system, and it may be true for other industries, is that our workforce market is thoroughly interdependent with each other. So the actions of one party implement on another. So the government and their pay dispute is the most obvious one at the moment. And that's because the levers for action are held by lots of different agencies at different levels of the system. And just to add a further degree of challenge, the impact of those levers happens over different timeframes. So having worked at HEE where our primary lever was training, the impact of that was always 5 to 10 years away. And yet people were looking for solutions in the here and now. So this is the landscape I'm going to try and take you through and describe some practical ways in which I think you might go about addressing this challenge. So integrated service, financial and workforce planning can be gone through as a series of kind of steps. It's not linear, it's definitely iterative, but it helps if you think about it in this way. And this isn't my ideas, these are ideas that are being done in terms of 6-step workforce planning and the WHO model, but they have a kind of a generic truth to them. And the first of those is you do have to think about where are the boundaries of my plan? What am I planning for your, basically to keep yourself sane, really. But the first thing you ask yourself is, what are our system goals? What is it we are trying to achieve here? And that might be in terms of service, but it might also be, as Jack's touched on, in terms of your workforce. Are you treating staff well to make sure you can afford the service, or is it a fundamental belief that you should treat them well? So you're asking yourself some fairly fundamental questions in that system goals place. You may add, let's be an economic anchor for our community. So the ICSs will certainly have a broader perspective of that system goals and potentially some of their provider colleagues who may think, I need to clear the waiting list. Those goals should directly say, how do you design your service and how do you pay for that? How do you go about it? What we've seen is that in this planning process, we haven't even touched workforce yet. We don't discuss what is the workforce requirement for those goals and for those services until we get to step 4. And this has been traditionally where we've fallen down. Traditionally, people have been given a workforce planning task that starts at box 4. And is simply not owned by the people in charge of the first 2, handed off to a CPO or somebody else and said, here's the challenge. Go and tell me how you're going to make the supply to meet some notional demand, but I'm not going to engage with you as to what the goals are or the service model is. And that's why I'm so passionate about this, is that I don't think that works. For me, that's been the main failing consistently through my 20 years of doing this. And we have some examples where doing it the other way works, the mental health plan, long-term work plan itself. You do need to then go through a discipline, though, that says, okay, if we've done those first 4 things and got a really good signal as to what our workforce requirement is, what is our supply? Are we going to be able to meet it? And if there's a gap, then you create an all levers plan. And by that, I mean, you go back round the loop and you consider all of the variables, not just the supply variables. So in this, you can see our traditional response would be best employer actions for recruitment and retention, current supply actions, temporary staff, international recruitment, or you turn around to HEE and say, train us some more for some vague point in the future. But you have to think about the team structure and the productivity of those team structures. But more importantly, you have to think about the service model and its productivity. And this is the really unpopular bit. If none of that works, somebody's got to be honest with the public and the politicians and say we can't meet those system goals. Now, this is why that is hard, because that final discussion is so difficult. The system goals are kind of given, the money's given, the funding gap that Jackie spoke to. So you just go down the line and you end up in the blue box saying, how do we get more to get it done? And we'll touch on that a bit more. And of course, you should then monitor and refresh it. So if that's difficult, and it is, it's made even more difficult because we're in a complex landscape where different people are planning for different time horizons. I'll touch on this in a second. We plan at different levels, from providers through to national, and we plan through different lenses, whether it's a plan for a whole organisation or geography, or through the lens of service pathways and professions. And again, as we've discussed, the actions that might change those things are held by different agencies with independent governance, and those actions are relevant to different timeframes. So you've got this huge alignment and coordination challenge. And one of the things I'm going to say to you today is you will be part of this landscape, not all of this landscape. You should act coherently in your plan, but you need to be aware of the plans around you and the external things that will affect you. That's not saying give up. What it's saying is do your bit well and be conscious and try and be aligned with other efforts. Really difficult stuff, but not impossible. And again, because we need service and financial, these are planning challenges, not workforce planning challenges. So one of the key variables is what time frame are you planning for? And here, when you think of most plans in the NHS, and I'm sure this is true in other industries, there's a lot of focus in the kind of 1 year plan, i.e. the budget, and next year, and probably up to 5 years. And that's certainly true in service planning. And certainly in the NHS, we're tied to spending reviews that only ever go 3 to 5 years out. So this becomes a very dominant part of the landscape. But we also know if you're on a ward, it's about rotas and who can I get in on a Tuesday. So there's, you know, and yet we call all of these things workforce planning, right? But so again, I'm not saying that that's not workforce planning. What I'm saying is be clear which bit of this landscape you're on. And then because of the training time lag, somebody needs to be thinking 5 to 15 years out. And ideally, you really want somebody to be thinking at the end of that spectrum, saying, what's our North Star? What we can see is that if we look at the NHS planning landscape, there's a real strong kind of correlation between those time horizons and the level at which we do planning. So operational management is a kind of, you know, ward service led thing. Annual planning is absolutely driven by providers and their systems. You know, the difficult commissioning provision discussion on an annual basis. At national and regional level, those are just an aggregate. You know, there is no such thing as an annual plan. It's just the sum of everybody else's plans. But when you get to multi-year planning, now, this really should be the sweet spot for ICSs. That's their purpose. But they're also responding to a wider framing, which is the long-term plan and what's been agreed through the spending review. And there is a question as to how many providers have multi-year plans. And are those in line with their system plans and system priorities? You know, we know there's a tension there. There's no point pretending there's not. And then the people who have responsibility for looking beyond that traditionally have only been national agencies. Whether that's right or wrong, that has been the kind of reality of it. And then we've got something called Framework 15, which was an attempt to look really long term at kind of North Star key drivers. Again, why I'm saying this is to say, be conscious of where your planning fits in this, and therefore what the actions of other parties might be on your plans, as well as doing your plan as well as you can. But if that's complex, we then have this, which says, most of you may be thinking I'm responsible for planning for my organization or for my system. But there are people within your systems who will say, I'm responsible for planning diabetes or mental health or cancer. And there'll be other people like your chief nurse or your medical director who say, no, I'm looking at individual professions. I want to know about diagnostic radiography or nursing or midwifery. Those aren't going away. People are always going to want to plan by service pathway and by profession. The trick is to make them coherent with each other. And one of the key things we know is that service pathways are always made up of teams. So they're always multi-professional. And those service pathways drive the demand for work. The currency of work is those kind of, you know, what are we going to do in the space of mental health or diabetes or whatever. Whereas supply is, in the NHS in particular, and this can be different for other professions, other industries, supply is driven by units called professions and roles. And that's just the way we are, with clinical professions being 50% of our workforce and having these long lead-in times associated with professional training. So don't get hung up on that, but acknowledging that's the landscape we're working in is really important to understand that you have this tension between demand defined by service pathways and supply defined by professions. Somehow we have to bring those together. So if that describes the landscape that I would like you to be able to navigate and appreciate that different plans will impact on your plan, however you've defined it, let's pivot back to the integrated planning approach. And your actual position, and I think, Jack, this does kind of resonate with your economic analysis, says there are actually some quite simple but massively strategic choices that first of all drive demand for workforce, which is the balance between your service ambition, how much funding you've got, and what productivity you can achieve. And if you think about fixing two of those, if you set your service ambition and you know what's deliverable in productivity, it would tell you what you need in funding. Government might not like it, right? Or if you set the funding and say this is achievable productivity, then it could define the ambition you can achieve, and the politicians might not like that. So sadly, we tend to end up with a third of those, which is the funding is set and the service ambition is set, and we end up with a magic productivity tree. You know, an assumption that we can deliver that ambition for the money, and off you go and do it. Now, I can't solve that for you, but I think having this in your head, so these are the three key things we are juggling with here, and trying to force rational discussions about them is definitely in your interest. It's something we try and do nationally. You know, this is Julian Kelly with the Treasury and the Minister's stuff, but that could also be true locally. Now, the trouble is that we don't have honest conversations in this space. We tend to obfuscate them with particularly ambitious productivity figures, which is true in the long-term workforce plan, by the way. And if that's total demand, there is this kind of subset that says, but demand for which role? And certainly the way you design your MDT can mean that can be different. So whatever the total requirement is, there may be different approaches to delivering it. And I think that's a really important thing. Once you've got that demand picture, the big silos for supply choices are being a good employer, the things that retain and recruit people, including not giving them onerous workloads, right? So these things are also interconnected. What can you do through international recruitment? And in the NHS, domestic supply through education is a big element, but in the future. Now, that may not be true for other industries where there may be less differentiation and less barriers to entry and exit of the worker. But this is certainly the kind of key elements that you're juggling with in terms of NHS planning. Two more slides quickly. So if you don't like the thinking about things in terms of model, the integrated planning model, for me, that translates into some really simple words that you're trying to answer in each and every planning round. Are you planning sufficient posts to deliver the service goals to the quality required within the resources available? Sounds simple, doesn't it? But that brings those things together. It makes you ask the question. This is the question that gets ignored most. You know, a figure goes forward saying this is what we can afford, rather than having a really serious conversation about, oh, have we got enough posts for what we need to deliver? This was partly the cause of mid-staffs, pretending you had enough posts to deliver the service to the quality required. But it's also an affordability question, which is also why it happened, right? Then you need to think, have we got the supply to meet that requirement? But making sure your requirement is grounded in the service goals. And then your third point is, and are we taking the actions to make those first two things credible? So for me, that's an easy ABC, little checklist that you can take through if you prefer that to a kind of process approach. So if that's the framework, why doesn't it happen? So this is a quick discussion about what is it about us as humans and systems that means it doesn't happen. And I could say it's these orange and blue boxes on the left, which is that the governance of service planning tends to be separate from the governance of workforce planning. But I think that's an excuse. I think this is cultural and behavioural. I think the people in that orange box are quite happy to pass you the workforce challenge as workforce practitioners. And my experience has been they've been uncomfortable being drawn in and saying the workforce plan is your plan. So how do we go about that? I've mentioned that the Jeremy Hunt experience and the COVID experience started to break that down. But strangely, it probably is you as health HR professionals who have to make that approach and have to start breaking that down and using this structure and saying, but we need to go through these steps is one way of doing it. And I've got lots of stories I could tell about how unintegrated plans became integrated because they failed. And the mental health plan is my favourite. We'll save that for breakout. Thank you, Nick.
Thank you, Rob. And some great provocations from both Rob and Jax there, some real insights just to reflect on. I'm sure we'll be thinking about those in coming days. But what we thought would be really useful is for you to break out into some small groups to have a bit of a conversation about what you've heard, what has resonated, what has not, what are the main opportunities and barriers you're having to deal with within your organization, what insights or tools or approaches will you share to inspire others within that group. I just want to remind people about the next couple of things. So the post-workshop call, would love to have a conversation with yourselves just to understand what parts of the webinar really made you think and why, and also to hear about your specific challenges. So for the first 10 people who book, we'll be sharing our thought piece that captures our thinking and ideas around strategic workforce planning. And then, of course, the next webinar on the 26th of March, Strategic Thinking and Delivering Complex Systems. Love you all to come to that. Do sign up at office@tricordon.com. But for today, I just want to thank you again and wish you a good evening. Thank you very much, everyone.